Hello, this talk is on nuclear medicine and the PET-CT imaging of lymphoma. PET imaging stands for positron emission tomography. It uses a radioactive material which is injected into the patient. This emits a positron which emits radiation within the patient's body. This radiation is imaged tomographically, which gives us the name positron emission tomography, a PET scanner. This is the typical MIP image you would get from FDG PET imaging. Once the image is acquired, we typically review it in axial, coronal, and sagittal images, and the PET images that are attenuation corrected would look like this. Typically, you would also acquire CT images for oncologic imaging. More recently, there are PET MRI cameras which would acquire MRI rather than CT. Once this is acquired, the PET images and the CT images are usually overlaid one on top of the other, which results in the PET-CT imaging. The radiotracers that we inject into patients to get these images are basically radioactive isotopes that are tagged onto different molecules, and depending upon the molecule we tag it to, we can image various processes within the body. F18FDG is the most common PET isotope used in oncologic imaging. Other tracers that are used to a lesser or greater extent include gallium-68 dodonok, PSMA. These are the more common ones. F18 sodium fluoride. The others are also used, for example, choline imaging is increasing, but not so much in oncology, but more in parathyroid imaging. F18FDG is a glucose analog, so it's taken up by cells just like glucose. A lot of cancer cells would preferentially take up more glucose than the surrounding normal cells. This will result in corresponding increased radioactivity in the tumor cells compared to the surrounding normal cells. So when you image the patients with PET imaging, you would see greater activity in the malignant cells compared to the normal cells, and that is the basis of FDG imaging in oncology. Because this is a radioactive analog of glucose, we typically ask oncologic patients to fast for about 4 hours. We prefer patients not to exercise within about 24 hours of the scan. Increased exercise will result in increased muscle uptake, which can compromise the study. Because, again, this is the glucose metabolic pathway, diabetic patients who have impaired glucose metabolism have special instructions for PET scans with FDG. We'll look at some images of normal distribution of FDG. So the brain is an area where you'd have high FDG uptake. It's usually more intense in the gray matter and the basal ganglia, as you can see over here. When you're looking at your oncologic PET scans, typically they will cut off at the base of the skull. Most centers do not scan from the apex. They would go from the base of the skull down to the thighs. If, however, you do see something like this, you should review the brain images. A good way to do this is to window the activity in the brain so you can appreciate the activity. This is similar to how you would window CT images. Instead of going for lung or bone, you would have brain windowing for the CT. So think of it as brain windowing for your PET images. As you can see on the fused images, you can see a lot more detail when you do that. Normal distribution in the liver is typically moderate. Most centers would window their PET scan to the hepatic level of activity. The uptake in the heart is typically low, as we see over here. As you can see on the fused images, not that much uptake in the walls of the ventricle. However, you can see high uptake, and this may not be significant on oncologic FDG PET imaging. In cardiac imaging, it would be a different story. Looking at the esophagus and stomach, there's variable uptake. If you see something like this would be considered normal, no significant uptake in the stomach. This is wonderful. However, if you see uptake like this, if you're not expecting malignancy, if it's more contiguous, it may just be normal uptake or mild inflammation. In the urinary system, it would depend upon how well hydrated your patient is. If you see something like this is pretty good. You're seeing some uptake in the kidneys. You're seeing almost no excreted tracer in the ureters or urethra. You see some activity in the bladder. This is pretty good. You can see the walls nicely once it's windowed. Other areas where you might see uptake include the gastrointestinal tract. Again, variable uptake. You can see increased uptake here in diabetic patients, particularly if they're taking metformin. You can see increased uptake if they're in the terminal ileum and cecum in lymphoid tissue. That's normal variant. You can also see uptake if there's peristalsis. You can also see uptake if there's mild inflammation. Other sites of uptake include the Walder's ring, salivary glands. You can also see uptake in the testes, uterus, and ovaries. So in menstruating women, uptake in the uterus and ovaries would be physiologic. You can also see uptake in the thymus in younger patients, and this is an important thing to note. You would typically see low levels of activity in the bone marrow and the muscles, as we can see here. So why do we do FDG PET-CT imaging? Metabolic changes can predate anatomic changes. So basically you can see malignancy on FDG imaging, but you won't be able to see it on the CT images. Small volume malignancies, which may not be considered abnormal by size criteria, would be considered abnormal on FDG criteria, so it would pick up more disease there. It can help by allowing the clinicians to plan more appropriate treatment. It can also provide prognostic information based on the amount of uptake. It can also detect coexisting disease in the patient. Now, FDG does have its limitations. It can have false positives and false negatives. False positives include normal variants like thymic uptake, physiologic uptake in brown fat. It's not limited to any one malignancy. Many malignancies can have uptake of FDG. Many non-malignant conditions can also show prominent FDG uptake. Also, patients who have undergone treatment can also have FDG uptake based on that post-treatment changes. This includes uptake in the bone marrow and spleen from chemotherapy and GCSF. You can have uptake in the lungs from post-radiotherapy, and you can also have increased uptake in the thymus from thymic rebound. Now, false negatives, some tumors are not avid for FDG. Some tumors may be very small, sub-centimeter, and you may not be able to see the FDG uptake they have, if any. This can often be seen in lung nodules. If the patient did not prepare well, then the study may give you a false negative because FDG was not localized. Normal glucose is competing with it for uptake. If you have high background uptake, for example, if you have a lot of gastrointestinal uptake, if you have a lot of excreted tracer in the urinary system, that may compete in finding a normal uptake in those regions. If the patient's been exercising, you may see a lot of uptake in the muscles. It may miss something normal there. We can see an example here of normal uptake in the thymus in a certain age group, up to about 25 years. This would be a normal variant, typically mild, diffuse. You can see increased uptake on thymic rebound, which can be a lot more prominent than this. Looking at the CT images, you can see this nice lace-type pattern. There's no solid mass here, and that can help differentiate it from lymphoma and other malignancies. It's important to do this because you don't want to recommend biopsy for normal thyroid tissue. Looking at uptake in brown fat, prominent FDG uptake can be seen in brown fat, and this is normal uptake. The sites can include the neck, axilla, the thorax, and the upper abdomen. It can be quite intense. So, for example, here you can see regional uptake here on the fusion images. So, are there nodes here? Are there nodes there? You need to look at the CT images to find out. A good way of reducing the uptake in the brown fat is to keep the patient warm, and there are other methods which we won't go into here. One problem of having uptake in brown fat is it can obscure true positive FDG avid nodes, where the uptake in the node is less than that in the brown fat, so it may be masked. So looking at these two images, take a second, try to guess which one is node, which one is brown fat. So as you can see from the CT images here, while this is more intense than this uptake, here there is a small node on CT, and this corresponds to a true node, whereas this more intense uptake just corresponds to fat on CT images. So this is brown fat and this is a true node. Moving on to post-chemotherapy changes, which we talked about a little bit earlier, you can see diffuse increased uptake in the bone marrow, which you can see here on the MIP images and here on the fused image. You can also see increased uptake in the spleen. We consider it increased if it's increased relative to the liver. This can be seen with chemotherapy and also with GCSF. Now, a lot of times when you're doing a PET scan, you'll see values like SUV max. So there are several equations used to calculate this. This is one of your basic equations. Most centers would use SUV max, which is the maximum voxel value of SUV in the region you're measuring. And that's the value that they'll report. There are many other measurements you'll find in the literature, including SUV mean, metabolic tumor volume, total glycolytic volume, and even SUV ratios. One important thing to note is whatever value you're looking at, measurements can and do vary from institution to institution because cameras process the data that they acquire for PET differently, and this results in a great variation in the SUV max measurements. So when you're looking at studies that are published in the literature, if they give an absolute SUV cutoff, it's unlikely that that will be applicable to your center unless it was from the study was done using the cameras you're using in your center and they've been calibrated the same way. FDG uptake in lymphoma. FDG is recommended to be used in all FDG-avid lymphomas and is used to determine staging in lymphoma. It can also look at transformation of low-grade lymphoma to high-grade lymphomas, and can also be used to find sites of transformation for biopsy. Looking at some of the common lymphomas, Hodgkin's tends to be typically very high FDG uptake. Diffuse large B-cell lymphomas, also quite avid. Follicular lymphomas can be variable. They can have low to moderate uptake. Marginal zone lymphomas, again, variable. CLL type of lymphomas can be variable, but they can be high after transformation, so that would direct you to the place for biopsy. Mantle cell lymphomas, again, variable. A couple of T-cell lymphomas can be high, others not so much. Looking at staging, if the routine use of FDG is recommended to be used for staging, and this is how it typically breaks down. If you have a single nodal group or a single extralymphatic lesion noted on imaging, that would be stage 1. If you have multiple nodal groups on the same side of the diaphragm, or you have limited contiguous extralymphatic involvement, that's stage 2. If you have multiple nodal groups involving both sides of the diaphragm with or without splenic involvement, that's stage 3. If you have any non-contiguous extralymphatic involvement, it's stage 4. Looking at Hodgkin's lymphoma, the nodal involvement is typically supradiaphragmatic. About 60 to 70% will present as cervical nodes. About 5 to 60% will have mediastinal nodal involvement, and about 30% will have axillary involvement. About 10 to 15% of patients will have extranodal involvement. Typical sites are the bone, bone marrow, lung, and liver. FDG is useful. It can upstage cases where you have bone marrow involvement that's not otherwise detected. It can also detect FDG-avid disease in lymph nodes that are not enlarged by size criteria. It can also help by downstaging patients, those who have enlarged spleens but normal FDG uptake, again normal relative to the liver. Or you can have enlarged lymph nodes which do not have prominent FDG uptake. So here's an example of a patient with FDG-avid Hodgkin's lymphoma. So if you look at the sites over here, 2 sites of intense uptake. You look at the bone window, you don't really see any changes on CT. This corresponds, however, to nodes you can see, even though this is the bone window. Here's another slice in the same patient, again, intense uptake. You can see it nicely in diffuse images. You look on CT, no changes. So this is bone involvement by Hodgkin's lymphoma in this patient. Here's another example of Hodgkin's lymphoma. So there's a 49-year-old gentleman. So here you can see on the MIP images, there are nodes above the diaphragm extending to below the diaphragm. You can also see there's a splenic involvement here. And you can also see there's involvement here in the manubrium. On CT images, you can see that for most of the site, there are not really any changes on CT imaging. Moving on to follicular lymphoma. This is the second most common type of non-Hodgkin's lymphoma. It has a low-grade uptake, typically generalized lymphadenopathy. Typical sites include the axilla, cervical, femoral, inguinal nodes, cervical, axillary, femoral, inguinal. Extranodal sites, typically seen, bone marrow is typically seen in 50% of cases. It can also involve lymphoid organs. FDG can identify sites of transformation from low-grade to high-grade lymphoma. The low-grade lymphomas are typically less avid than the high-grade lymphomas. Here's an example of follicular lymphoma, 57-year-old lady. So you can see diffuse uptake in the spleen. So this is positive for involvement. Again, splenic activity greater than hepatic activity. You can also see on the MIP images, diffuse activity in the bones. Here, again, greater than hepatic levels of activity. You can also see a lot of nodes involved in this patient, both above and below the diaphragm. So diffuse large B-cell lymphoma, typically in large nodes. In about 40% distribution would be to one side of the diaphragm. In about 20% it would be above and below the diaphragm. In 30 to 40% of patients it would be widespread and extranodal. Extranodal sites would depend if it's a primary extranodal origin diffuse large B-cell lymphoma. It would be gastrointestinal, thyroid, bone, brain, testes, kidney, liver, breast, and skin. Sites of extranodal spread include the lung, liver, kidney, and bone marrow. FDG, typically high FDG uptake. It's good to note that even if a patient is FDG negative, it may be worthwhile getting a bone marrow biopsy. Transformation to diffuse large B-cell lymphoma. So 5 to 7%, follicular lymphomas, about 5 to 7% have an annual rate of transformation to diffuse large B-cell. Chronic lymphocytic leukemia has a 2 to 10% Richter conversion. And FDG can identify sites for biopsy, as the converted sites tend to be more avid than CLL or follicular lymphoma. Looking at MALT lymphoma. So the stomach is the most common site. Other sites include ocular adnexa and the lungs. Less common sites at the gut, lacrimal, salivary glands, skin, soft tissue, thyroid, breast, and synovium. You would have disseminated disease in about 25 to 50% of cases. Bone marrow involvement 5 to 25%. FDG PET-CT is useful for staging MALT lymphoma. We see a case here, a 59-year-old lady, so has known right orbital MALT and lung involvement, and there's diffuse bone uptake seen on FDG. But over here you can see that the MALT lymphoma over here is intensely FDG avid, again greater than hepatic levels of uptake. And here you can see the lung nodule, not so avid, but it's again the known involvement by MALT lymphoma. So the nodal patterns, just to go over a summary of what we've talked about already. In Hodgkin's, the nodes would typically be contiguous nodal extension, usually supradiaphragmatic. Follicular, typically generalized, can involve the axilla, cervical, femoral, inguinal nodal stations. Diffuse large B-cell lymphoma, and about 40% would be one side of the diaphragm, 20% would be both sides of the diaphragm. MALT lymphoma, typically extranodal involvement. Looking at extranodal lymphoma, Hodgkin's, about 10 to 15% in presentation would have extranodal involvement. Typical sites would be the bone marrow, lung, and liver. For follicular lymphoma, it would be typically bone marrow involvement. Diffuse large B-cell lymphoma, if it's primarily extranodal DLBCL, it would be gastrointestinal tract, thyroid, bone, brain, testes, kidney, liver, breast, and skin. For spread, it would be lung, liver, kidney, and bone marrow. And for MALT, the stomach is the most common site. Looking at splenic involvement by lymphoma, we saw an example recently where we had intense diffuse uptake. So again, it should be greater than hepatic levels of uptake. You can, however, have focal uptake, as you have over here, which is again greater than hepatic levels of uptake, and this would be abnormal even if the spleen is normal in size. Looking at FDG and bone marrow biopsy, so a bone marrow involvement typically identifies lymphoma patients who are high risk and alters the management of those patients. So about 10% of newly diagnosed Hodgkin disease patients and 25% of newly diagnosed non-Hodgkin's patients would have this. This is an indicator of poor prognosis. So when would you not need bone marrow biopsy? If you have a negative PET-CT in Hodgkin's disease, if you have diffuse, homogeneous, nonspecific bone marrow uptake in Hodgkin's, so this would be considered ruling it out, this would rule it in. If you have focal uptake in Hodgkin's disease and non-Hodgkin's disease, this would also rule in disease, so you would not need a biopsy. When might you need a biopsy? If you have negative PET-CT in diffuse large B-cell lymphoma, then you'd probably want to get a biopsy. If you have diffuse bone marrow uptake in non-Hodgkin's lymphoma, you might need a biopsy. And if you have low-grade non-Hodgkin's lymphoma, which may not be FDG avid, you may consider a biopsy. Moving on to treatment response, we'll start with the DeVille score, which is a visual analysis of FDG uptake and uses a 5-point scale to interpret the uptake for treatment response. You want to make sure you have a pre-treatment scan because that's what you use to compare on follow-up imaging to see if there's a response. A score of 1 means there's no FDG uptake. A score of 2 means the uptake is less than mediastinal blood pool. A score of 3 means it's greater than mediastinal blood pool but less than or equal to hepatic levels of uptake. 4 means moderately increased uptake compared to the liver. 5 means markedly increased uptake compared to the liver. This is more than 2 to 3 times hepatic levels of uptake. Or if you're following up, this would also mean if you have new lesions which you think are lymphomatous involvement. A score of X means you have a follow-up study, you see new areas of uptake that you feel are unlikely to be related to the lymphoma. As we said, the DeVille score is primarily visual assessment. St. Thomas's Hospital in London, they looked at how you could do a quantitative measurement. So they used SUV max measurements. They drew areas over any residual areas of suspected lymphoma, if present. They drew areas to look for normal mediastinal uptake. They drew areas in the arch of the aorta, or just above the aortic root in primary mediastinal B-cell lymphoma. They made sure they avoided the vessel wall or any areas of calcification. For hepatic uptake, they avoided the edge of the liver. They avoided any single hot pixels, which might represent noise. They tended to sample several slices to get a representative SUV max level for the liver. Then these numbers were used to compare areas of residual activity to the values of mediastinal and hepatic activity to generate the DeVille score. So here we have some examples. Looking at this area, this is a node. Look at the uptake over here. Looking at blood pool activity and looking at hepatic activity, this seems to be greater than mediastinal blood pool levels of uptake, but is somewhat similar to hepatic levels of uptake. So this would be DeVille score 3. Looking at this region over here, you can see this region of uptake on PET imaging is definitely greater than hepatic levels of uptake. So this would be DeVille score 4, moderately increased uptake, about 2 to 3 times hepatic levels of activity. And looking at this rather intense uptake over here is definitely more avid than hepatic levels of uptake and markedly increased, definitely more than 2 to 3 times hepatic levels of activity. So this would be DeVille score 5. Moving on to the Lugano classification of treatment response in lymphoma patients, looking at the FDG PET-CT criteria. This uses the DeVille 5-point score. It compares the baseline to the interim or post-treatment scan. If you're comparing it to the post-treatment scan, you want to make sure you have a gap between chemotherapy, about 6 to 8 weeks, about 2 weeks after GCSF treatment, or about 3 months after radiotherapy. As we've seen, this post-treatment changes can cause intense uptake, which may mask residual lymphoma. This uptake of FDG also has prognostic value in several types of lymphoma, as described here. Looking at the response criteria, if the score post-treatment is a 1, 2, or 3, with or without a residual mass on CT and no uptake in bone marrow, is considered complete response. Some centers consider 1 or 2 as a de-escalation cutoff, and if they have a 3, they may still proceed with some form of treatment. For partial response, a 4 or 5 decreased from baseline. That means it's still greater than hepatic levels of uptake, but it's decreased from the baseline scan, and there's no new FDG-avid lymphoma, then this is considered partial response or responding disease. Stable disease would be 4 or 5, so it's greater than hepatic levels of uptake, either moderately or intensely, and it hasn't really changed from baseline, it's stable. However, there's no new FDG-avid lymphoma, no changes in the bone marrow from baseline, so this would be no metabolic response, stable disease. Progression of disease would be if it's 4 or 5 that has increased from baseline, so again greater than hepatic levels of uptake, but increasing when you compare the baseline scan to the treatment scan, and if there are new FDG-avid lesions that are likely to be lymphoma. So the Lugano criteria recommends routine use of FDG PET-CT for all FDG-avid lymphomas, which is most of them. So looking at this table here, we again summarized some of the features for our various types of lymphoma. For Hodgkin's, it progresses in nodal changes. Typical uptake is high. In late cases, you can see systemic involvement, diffuse large B-cell lymphoma, about 30% extranodal disease. You can see nodal masses with DLBCL, typically highly FDG-avid. Follicular indolent, you can see diffuse adenopathy, variable uptake. Marginal, you can have different types. You can have variable uptake depending on the type. In small lymphocytic lymphoma of CLL type, again a variable, but once it transforms, it will be high uptake. And mantle cell lymphoma, gastrointestinal bone marrow uptake, again variable. Looking further at treatment response in lymphoma, a PET-CT scan after one cycle of chemotherapy has been reported as being more accurate than doing a scan after completion. Looking at FDG mid-treatment, if there is residual uptake, this might mean that you can have ultimate progression of disease, that ultimately you will not have complete response, or you may have rapid response even after temporary complete response. If you have a negative mid-treatment FDG scan, this usually means you will achieve complete response post-treatment. So here's an example of a patient, a 54-year-old with B-cell lymphoma, hepatic SUV max is 3.2. This large lesion over here is rather FDG-avid, 18.6 pre-treatment. Post-treatment dropped to 7.6. On the 5-point scale, this decreased from a 5 to a 4. On the scan, we saw no new FDG-avid lymphoma. So even though it's still FDG-avid, still greater than hepatic levels of uptake, it has decreased, no new lesion. This would indicate partial response. Looking at the Lugano criteria and response in lymphoma, if we have residual masses in the mediastinum that are seen on CT, we will see this in about 50 to 64% of patients with Hodgkin's, 20 to 60 with non-Hodgkin's. It could represent either fibrosis, necrosis, or active tumor. So if we look at our score, the score of 1 or 2 is considered to represent complete response. 3 could mean good response, or it could mean that it's undertreated. 4 or 5 could mean that it's an interim, it's reduced from baseline, means that it's chemotherapy-sensitive disease. At end of treatment, if you still have a 4 or 5 in these mediastinal masses, it means treatment failure. So FDG in Hodgkin's and non-Hodgkin's for these mediastinal masses has a high positive predictive value and high negative predictive value. So in summary, FDG PET-CT is integral in lymphoma management. It's useful for staging and for assessing treatment response. The DeVille 5-point score and the Lugano classification are used to assess lymphoma avidity and response. It may be visual or it may be quantitative. If quantitative, remember that the SUV values can vary from institution to institution. So if you're comparing a PET scan to one that was done elsewhere, you won't be able to compare the SUV values unless you've calibrated your cameras. Similarly, if you're looking at literature, be aware that the SUV values can vary, so something published elsewhere may not apply to your institution. Lesions can be FDG-avid with no changes on CT, as we see over here, intensely FDG-avid bone lesion, no changes on CT. FDG PET-CT scans can upstage lymphoma, and they can also downstage lymphoma patients. And in patients with suspected Richter conversion of lymphoma from CLL to diffuse large B-cell lymphoma or follicular lymphoma, low-grade to high-grade lymphoma, it can help identify sites for biopsy. Thank you. Hope you enjoyed the talk.